咁我先講 introduction 先，好冇？唔好意思，大家重複下。好歡迎大家嚟到呢個線上講座啊！我係香港危重病學會主席沈海平醫生。咁我哋好高興咧，今日我能夠請到一個重量級人物喎，黎鏡堯醫生嚟同大家講 talk。咁黎醫生本身係伊利沙伯醫院深切治療部嘅顧問醫生，亦都係我哋嘅香港危重病學科嘅教父級人物嚟。咁咧，佢對新冠病毒咧同埋流感病毒咧有極之深入嘅研究同分析。咁今日佢嘅題目非常特別啊，咁所以我都好期待。咁事不宜遲，不如我交俾阿黎醫生開始講個 talk。唔該晒。
Thank you for your kind introduction. Actually, my topic today is on the therapeutic strategy against a non-mutable part of encapsulated RNA viruses. And you know that in the past 100 years, we are able to control many DNA viruses because they are not mutating. But for the RNA virus, they are mutating all the time because they do not have a good proof mechanism for the replications. SARS and COVID are quite different because they have some mechanisms to prove the case during replications. And this is the SARS-CoV exonuclease. And with this, the mutation rate of COVID is about only half of influenza and only a quarter of HIV. And the presence of this approved mechanism makes some of the drugs which are useful for RNA virus ineffective. For example, viral. Because of the presence of this approved mechanisms, it requires 300 times the usual dose in order they can suppress the replication of COVID, so that this drug is ineffective in the treatment. In the new drugs that we are treating for COVID, most of these drugs can escape this approved mechanism because they are not recognized by the viral exonuclease. And I chose this topic is that why I chose this topic is that is the approach in the treatment of this rapidly mutating virus. And I call it from some of the Buddha history. And I would translate say in Cantonese because it's very difficult for me to translate. 當年咧佛祖咧初成正覺，咁第一樣嘢咧就話奇哉奇哉，一切眾生皆具如來智慧德相，但以妄想執着不能得正。跟住佢就係喺華嚴會上咧為天人説法，講他去自證圓滿境界。跟住咧就用咗49年為眾生説法，於法華涅槃會上咧大修與群心，證他圓滿，令眾生也能成佛。咁臨走喺涅槃經嗰度咧，佢個主旨咧就為咧眾生皆有佛性。咁所以嚟講咧，既然咧眾生皆有佛性咧，核糖核酸病毒當然有佛性啦咁樣，但係佛性係不二嘅。咁所以嚟講咧，核糖核酸病毒咧嘅佛性咧係相同嘅。如果我哋可以了知咧核糖核酸病毒共同不異嘅佛性咧，只可以應對咧萬變嘅病毒啦咁樣。其實呢啲嘢唔係新嘅。其實咧中醫咧用咗相同嘅理念咧，殊途同歸咧，醫咗我哋中國人咧2000多年啦。咁一陣間咧，我成個 presentation 咧個重點咧就係解釋咧係點解可以咁做咁樣，同埋咧佢嗰個不異呢啲病毒咧不異嘅佛性咧喺邊一度咁樣。And in the SARS the COVID outbreak on March 11, and there are several factors leading to the outbreak in different countries. The first is in the United States. Before March 11, there was no test kits that can confirm the diagnosis of COVID. In the UK, they use herd immunity to combat the pandemic. And like Singapore, Hong Kong, and Taiwan, the influx of the cases from the airport. And Taiwan have changed the quarantine policy from 14 days to 3+11. And this caused an outbreak with a death of 800 citizens. And also in India, because of the gathering in the March 11, they call Delta variant, leading to death of millions, death of million infected. And in Hong Kong, we introduced the vaccine pass only from the 24th of February, and which is too late, I think, and caused an outbreak in Hong Kong. And from the genetic point of view, some people are particularly susceptible to severe disease and death associated with COVID and SARS. And one of the genes is HLA-B46.01. And actually, if you look at the distribution of these genes, the most is densely distributed in China. So that if China do not use a zero COVID policy, I think that there will be a major casualty in China because of the outbreak of COVID compared with other countries. And in Hong Kong, they have done a study and found that if you have 3 doses of vaccinations, actually your protections is nearly 100% against severe illness and death. And if you look at China, actually, because the vaccine policy starting in the not in the elderly as the in the West, and so that a majority of the people in the range of 60 to 80 have not been vaccinated with 3 doses of vaccine. So that this is the reason why China cannot open up at this present moment. This is also the case in Hong Kong. We found that with 3 doses of vaccinations, we can protect our citizens, even for our elderly citizens, from death or illnesses. But however, if you look at the population from 60 to 80, many of them have not been vaccinated with 3 doses. So that until, I think that until the vaccination rate of this population has improved, we cannot open up at the present moment. And because of the outbreak in Hong Kong, China has come to help, both from the Western medicine specialists and also from the traditional Chinese medicine. And also Dr. Yan from Pamelayo Hospitals has come to QE to help us after we have converted to a COVID hospital in the 13th of March. So that I have the opportunity to share with them some of my views on COVID, and also with the traditional Chinese medicines on why Western medicine and Chinese medicine are complementary. If you look at the RNA virus as a whole, we have 2 types of viruses. One virus is that they are more stable, and we can get effective vaccinations for them. And they are not causing problems, which is this type of viruses. But for the virus that are hunting us, usually have zoonotic origins, and they are mutating all the times. So that even for influenza, we have to do the influenza vaccine yearly because of the rapid mutations. So that if you look at the virus in this way, then we are chasing after different shades of the moon. And in Chinese, 月有陰晴圓缺，而觀諸法生滅，世間無常。So that we have difficulties in chasing after them because their mutation is so rapid. They will so rapid that we cannot perform effective treatments for them. And this apple actually is mutated apples. 1 in 1 million apples will have these mutations. Just like the influenza virus, even the mutation of the hematopoietin and neuraminidase genes, we have a mutation and reassortment, genetic drift and shift, epidemic and pandemic and vaccinations, because of the rapidly mutations without proved breeding mechanism. And from the COVID, actually, the combination and permutation of the Delta, Beta A1 and Beta A2 have devised different combinations of new mutants over months. But however, if you look at the moon, actually, the moon have not changed. 所以從月影嘅天魔幻上，我哋可唔可以睇到背後暫然不動嘅特性咧？咁樣 And actually, the moon have not changed in the past 4.4 billion years. So that what is the non-mutable part of the viruses? The non-mutable part of the viruses is human cells. The whole cell is the non-mutable part of the RNA viruses. So that in the current vaccination program, monoclonal antibodies and antiviral medications are direct against the mutable part of the RNA virus, which is prone to rapid evolution within the whole cells. But you know that all viruses are obligatory parasites that largely relies on the whole cell factors and physiological process for its entry, replication, and egress. So the therapeutic agents direct against non-mutable targets of the host is independent of viral mutations. They have a complementary role to those therapeutic agents under development that are direct against the mutable part of the viruses. So that this is the method that the traditional Chinese medicines are doing in treating our patients. And the thinking of this is from one of the Buddha's 文殊師利所說不思議佛經戒經，佢話咧無如是平等正覺嘅佛經戒咧，係喺眾生嘅煩惱中談。凡夫起貪嗔痴處，便是如來所住平等法。It means that our human body and our human cells are the non-mutable part of the viruses, and we should target on this to improve the management of our patients. So that in the coming sharing, I would like to share how can we target our own non-mutable system to treat this type of viruses. Most of these viruses we have mentioned are encapsulated virus. They have to enter cells through the endosomes. And they have to undergo a pH-dependent conformational change and split by some enzyme in the endosome. That is campesine L and campesine D. This is influenza viruses, Ebola viruses, and also COVID, SARS, coronaviruses all use the similar mechanism. So that we have several drugs which are effective in targeting the the pH-dependent lysis of this protein in order to for them to come into our body. One is chloroquine, one is teicoplanin, and one is interferon B. Interferon B is can induce interferon transmembrane protein to limit the travel of the viruses into the cells. But for this, COVID is not very effective. I will mention later because COVID does not use this endosomal pathway for the viral entry. So that the chloroquine and interferon B is not effective in treating COVID, nor teicoplanin. But actually, it may be useful when sometimes, for example, influenza. For the use of teicoplanin, I would like to share my experience. And another is Omicron. Omicron is quite different from other COVID. Actually, Omicron used the endosomal pathway as one of the major viral entry. But because it's and it has been published by two major articles. But its role of this, for example, teicoplanin in treating this special Omicron have not been tested because in the previous strain, it's not very effective because it's not the major site of entry for other COVID viruses. And this is for the Ebola viruses. And I think the influenza viruses is one of the viruses and best illness strain. We can tackle our own body system to control the viruses. Because the influenza virus is a very different compared with other viruses, is that it makes full use of the nuclear factor kappa B. Because nuclear factor kappa B is trying to limit viral infections. But however, influenza virus has used nuclear factor kappa B for its own propagation and replications. So that nuclear factor kappa B activation is a prerequisite of influenza infections. If you do not have nuclear factor kappa B, then influenza cannot replicate inside your body. So that the first thing we have to know is that what lead to the nuclear factor kappa B activation in our body. Usually our body sends influenza virus infections in two ways. The first is that it has produced a lot of protein. And during the production of protein, it causes ER overload, endoplasmic reticulum overload. It induces a reactive oxygen species. So that because of this reactive oxygen species, it induces nuclear kappa B activation. Secondly, it produces a lot of RNA, single-strand RNA and double-strand RNA. It will stimulate the toll-like receptor, and this will also activate nuclear factor kappa B. Another that will activate nuclear kappa B is co-infections. Influenza virus have PP1F2 proteins, which will increase the chance of infections, bacterial infections. And bacterial infection can also induce toll-like receptor 2 and toll-like receptor 4, and this leading to nuclear factor kappa B activations. So that in order to control this nuclear factor kappa B activations, we have several methods. One is to block the reactive oxygen species, and then we can use high-dose NAC. Another is to use the paracetamol and COX-2 inhibitor. Obviously, we need to control the viral load, and secondly, we would also need to control the bacterial infections. During the novel H1N1 pandemic, I found that NAC, high-dose NAC can control the cytokine dysregulations quite well, except in two conditions. The first condition is that they have secondary bacterial infections, and this needs to be under control. And secondly, if you have a very high viral load, they have a high viral load, and we can use, they would need to single-strand RNA, which cannot be controlled by NAC. And incidentally, and at that time, the most difficult to control is secondary bacterial infections. And during one of the, because when you have a secondary bacterial infections, you would lead to a 10 times increase in mortality. And so that the pneumococcal vaccination is necessary to prevent these co-infections, because it contributes to, many of them contributed to co-infections in influenza infections. And during one of the treatment, I found that actually teicoplanin can actually is very effective in treating this organism. Novel H1N1. Probably, I think that in addition to treating the bacterial infections, it also have limited viral replication. And how about SARS coronavirus? SARS coronavirus actually do not want to induce a lot of cytokine dysregulations, so that they have closed all the single-strand RNA and double-strand RNA in the double membrane vesicles, so that they try not to stimulate the nuclear factor kappa B. During the treatment of influenza, I find that several viruses are also responsive to high-dose NAC. One is the ordinary coronavirus, RSV, and metapneumoviruses. But in the treatment of SARS, we have also introduced certain drugs. This is the dexamethasone, tocilizumab, and baricitinib. And actually, they are all working downstreams, and quite non-specific. And there's one study in the Spanish one who found that even with a dosage of 600 milligrams every 8 hours, they can improve the mortality, very similar to steroid and enoxaparin. Actually, this is a very low dose compared with the we use in influenza viruses. In the study of influenza virus, we are using 100 milligrams per kilogram, which is quite a high dose. And oral dose, actually, the oral availability of NAC is only 10%. So that this is extremely low dose as far as for the cytokine dysregulation compared with cytokine dysregulation of influenza. Perhaps from the previous communication with Zhong Lamsan, when during this early COVID outbreak, they use a lot of high-dose NAC for the treatment of the patients, and they are using thing as mucolytic agents. But I think that the most effective is not as a mucolytic agents, but as cytokine dysregulations. And also during the recent communication with the ICU specialists in China, they seldom use steroid for the treatment of patients. And one of the reasons I think that perhaps they have traditional Chinese medicine. And second is that they use a high-dose NAC, so that by suppressing the cytokine dysregulations, they can no need for the use of steroids for the management of the patients. During steroid management of our patients, we experience a lot of herpes simplex reactivations, CMV reactivation in our patients. So that we have to monitor every week whether they have the CMV has reactivated, and we have to this may have a negative effect on the pulmonary recovery of our patients. And the second point I want to say is that during the viral entry, actually they have an area in the body. The virus have an area we have to interact with the body, which is the non-mutable part of the viruses. For example, in the influenza viruses, they have usually they have an area which are highly conserved. I think why they have this highly conserved area is this is the particular point that interacted with the human cells. And this have a possibility of doing universal interferon antibodies, and also to reduce mortality. Though you can have a universal vaccine and universal monoclonal antibodies. However, it's more complicated. So that for the universal monoclonal antibodies, they are 3 types, and they are treating different types of influenza viruses. One type is you can treat influenza A and B, and one is only into group 1, and one is only treating group 2. But they are all under investigations. And this also is the same for another encapsulated virus, that is the Ebola viruses. And they also have a monoclonal antibody cocktail for Ebola viruses. And they are also finding there are some universal antibodies that can treat different types of Ebola viruses. And similar for COVID. You know that the spike proteins is divided into different parts. And some parts are highly conserved. If you look at the SARS proteins, the HR2 actually is highly conserved. It's the same for SARS-CoV viruses and SARS and also COVID viruses. So that some patients' antibodies against previous infection of SARS can protect against COVID. If they develop this antibody against these highly conserved areas. And there are different types of pan-coronavirus fusion inhibitor that developed for SARS treatment. But what is the most efficient way having this universal antibodies? I think it's by vaccinations. They found that, for example, if you have given 3 doses of coronavac, then actually in some of the patients have already developed some universal antibodies. We can neutralize all SARS-CoV variants. And they are also trying to obtain this monoclonal antibody to see whether they can be used for other human beings. So that I think the 3rd dose and the 4th dose is necessary in order to elicit a good T-cell response, and also have some development of these universal antibodies against the variants. Another problem is on the Omicron specific boosters. And for the messenger RNA, initially, two companies have tried to develop Omicron specific booster, but the product is delayed because some of the early study in animals had found that actually there was no specific advantage for the Omicron specific booster compared with current vaccine. So that Pfizer has delayed its launch of Omicron specific vaccine, and also Moderna are trying to build bivalent vaccine. That is, one is Omicron specific and one is the previous strain in the new vaccine. And there are various vaccines under trials to develop this Omicron specific vaccine. And in the second series, I want to discuss some co-receptors which are important for the infections. One of the co-infectors is on the endoepithelium, which is on the furin cleavage site, the binding with this is neurophilic. And this will increase the infections in the upper respiratory tract. Another co-receptor is the heparin sulfate, which is the membrane ground. This will lead to the pathogenesis of cerebral venous sinus thrombosis. And in 1997, with an outbreak of highly pathogenic avian influenza viruses. Avian influenza viruses are divided into two types. Yes, a highly pathogenic, and one is a low pathogenic influenza viruses. And this highly pathogenic influenza viruses lead to a rapid death of the poultry. For the low pathogenic avian viruses, the poultry will not die. They get infections and can recover. And the difference between highly pathogenic avian viruses is the presence of multi-basic amino acid in the hematopoietic cleavage site that allowed it to be cleaved by non-specific proteins, for example, furin. And because of that, the influenza viruses can break into the many parts of the body who have proteins. For example, in human beings, the influenza is limited to the lung only, and we seldom have a so-called viremic phase because they are not breaking down by non-specific furin inside the body. And they found that actually from most of these highly pathogenic avian influenza viruses come from a low pathogenic influenza viruses. And not all influenza viruses can mutate to highly pathogenic influenza viruses. Only the X5 and X7 have the potential to grow into highly pathogenic influenza viruses because of the editing. However, it can be genetically manipulated, including other types of influenza viruses, and turn it into a highly pathogenic influenza viruses. And this type of manipulation of this basic site is very common in research. In 2011, in the end of 2011, the FDA has stopped the propagation of one in Nature and one in Science because the investigate the study is how to turn H5N1 to be transmissible by droplets. And 6 months later, these two publications are allowed to publish. So that I have discussed with Professor Yun and Dr. Dominic Zhang. And they think that yes, because the resultant viruses, although they can be transmitted by fluid, by droplets, they are not pathogenic. So that they think that it is an epiphenomenon. But I think that I told them that actually they must have deleted the most important part before they are allowed to publish, because this propagation is in Nature and Science, and the pathogenicity should not be tested on ferret. They should test on human cells. But I have not seen in the articles that they have tested pathogenicity in human cells. So that I think that this is the two parts that had been deleted before publications. I use two examples to illustrate that. One is the Spanish flu. The Spanish flu is not very pathogenic in rats, but in mouse, but it's very pathogenic in humans. And then low H1N1, which is not pathogenic in pig, but however, it's very pathogenic in humans. So that without testing in human cells, we do not know the pathogenicity of these viruses. But from these two groups, I think that the Copenhagen has done a very good job, because they have tried to delete the polybasic site before they do the experiment. But however, for the Japanese group, they use the most lethal, that is the Indonesia one, who have 80% mortality in the transmission study. And this special H5N1 is not pathogenic to pigs in Indonesia. So that this is a varying event. And from this, we know that this polybasic site can be incorporated into the virus and deleted from the virus, and which is prone to scientific manipulations. And for COVID, there are two types of viral entry methods, three types of viral entry methods. First is for the endosomal one. This is later proof that is not the major site of entry for the COVID, except for Omicron species. The most common is due to the direct entry, because of the presence of the polybasic site for the in COVID, and also by cell-to-cell fusions. This is unique, is not present in SARS coronaviruses. The furin cleavage site is not uncommon in human coronaviruses. For example, half of the seasonal coronaviruses have furin cleavage sites. And also MERS COVID contain also a furin cleavage site. But the remaining strain and SARS-CoV do not have this furin cleavage site. And this is the other viruses also have a furin cleavage site, for example, HIV, and also in influenza, highly pathogenic influenza viruses and Ebola viruses. But what is the peculiar for this strain is that they have 12 nucleotides, which have replicate of some MSH3 messenger RNA genes in human bodies. So that there is a controversy what is the the coming of this polybasic site for SARS coronaviruses. But we are not interested. We are not interested on the origin, but rather what is the contribution of this site on the pathogenesis of COVID. And one is the binding of the neurophilins. And with the presence of this site actually lead to the infectivity of the COVID compared with SARS, because they can replicate very rapidly in the upper airway cells and the upper human airway epithelial cells. And this will increase their disseminations from patient to patients. And this furin cleavage site is important for the transmission in ferrets. And the disruption of this furin site is identified as the most promising strategy to produce live attenuated SARS coronavirus, which are in study. So this site is important. And also, this will increase the negativity of these viruses. And this have important increase the binding to AC2 and also the infectivity. For example, even for Omicron, you know that for the one of the increase in infectivity of the Omicron is that during the mutations, they become positively charged. And so that they can attach to the AC2 more securely. And also the cleavage site is important to the fusion transmission of this COVID. This is a mechanism which is absent in SARS. So that this cleavage site have increased the infectivity and the cell-to-cell spread by COVID. And this type of transmission is unable to be blocked by antibodies. And now we are sharing on the pathogenesis of COVID in the pathogenesis of cerebral-venous sinus thrombosis. One is the adenovirus, adenovirus vector that COVID vaccine induced immune thrombotic thrombocytopenia, which is a rare event. The most frequent cause of cerebral-venous sinus thrombosis is actually a natural COVID infection. And a remote possibility is due to the messenger RNA vaccinations. And I will discuss all three in sequence. For the instance of cerebral-venous sinus thrombosis, for example, in the United States, the background rate is around 0.53 to 0.77. In the original study, the set is 0.41. And so that in COVID infections, actually the incidence is increased 100 times. It's 42.8. But for the messenger RNA vaccination is 4.1. So that is not low, but because of the number of cases is small, so that it is not statistically significant. But judging from the incidence of cerebral-venous sinus thrombosis from Johnson and Johnson, actually it's only 1.4 per million populations. And even for AstraZeneca, it's only around 5. Although it have a very they different in different populations. The general health in the United Kingdom is 4, but in Finland is 40. So that actually there's a wide range of the incidence of this cerebral venous VITT for AstraZeneca. And this may be related to the interplay of the heparin sulfate proteoglycans on the endotheliums. And which area of the body have the highest concentration of this proteoglycan in the presence of AC2? This is our cerebral venous system and the portal vein. So that cerebral venous sinus thrombosis and portal vein thrombosis is one of the complications of natural COVID infections. And also, this is the place when you have antibodies against the heparin-induced thrombocytopenia. This is the site that they would cause. And as far as the VITT is only observed in the adenovirus vector vaccine, either from the AstraZeneca and also Johnson & Johnson. The incidence of Johnson & Johnson is 1.7 per million. But for the AstraZeneca, I mentioned is actually 4 to 40. 4 is for the United Kingdom, and in Finland is 40. So that there's a wide range of incidence in different patients. And it is very similar to autoimmune thrombocytopenia or heparin-induced thrombocytopenia. And they have antibodies against the platelet factor 4. And this this patient have not been a previous exposure to heparin. And they can activate platelet in the absence of heparin, and the platelet activation was inhibited by high level of heparin. So that is a mystery on why this type of vaccine will induce as heparin-induced thrombocytopenia type of features. And there are a lot of receptors for the adenovirus. The most commonly quoted is a Coxsackie adenovirus receptor. And they found that actually these 3 types of adenovirus factor actually can bind with the CAP and also platelet factor 4. And most likely is these interactions lead to the production of platelet factor 4 antibody and induce heparin-induced thrombocytopenia syndrome. And because heparin sulfate is highly concentrated in the portal vein and also the endothelium lining the cerebral venous sinus, so that this lead to the complication of cerebral venous sinus thrombosis or portal vein thrombosis in patients with this vaccine-induced thrombotic thrombocytopenia. Another possibility is that if you look at this adenovector vaccine, after they are injected, actually they will be cleared by the liver. But the liver do not have this CAP receptor. So that's why they are cleared by the liver, because actually they have a different mechanism. They have the mechanism is through factor 10 or factor 9 and also complement. And this acts as an intermediate receptor, so that finally this adenovector vaccine is cleared up to the liver by the heparin sulfate as a receptor. So that another possibility of this heparin-induced, the induction of heparin-induced thrombocytopenia is the production of this interaction of the heparin sulfate on the endothelium of these liver cells. So that there are two possibilities. As far as the vaccination, natural COVID infection is concerned, they have the highest incidence of cerebral venous sinus thrombosis is on the first 2 weeks, but it can also occur in the 4th to 6 weeks. And from the study, over 500,000 populations, they found that actually the incidence of cerebral venous sinus thrombosis after messenger RNA vaccination is the same as AstraZeneca, and is a much higher incidence of portal vein thrombosis. And one of the possibility is that this is induced by the spike proteins, which we will explain later. So that natural infections can, and also the spike protein, the presence of spike protein, can be concentrated by the heparin sulfate on the endothelium of the portovenous system or the cerebrovenous system to interact with the ACE2 and leading to thromboinflammation on the endothelial cells. And from this, it induced thrombosis of the portovenous system and also cerebral venous system. Also, it can invade the endothelium, but they found that mostly this is not the direct invasion of the viruses, rather thromboinflammation initiated induced by the viruses or the spike protein that is released from distal infections. So that what is the role of the heparin sulfate in increasing the interaction of ACE2? The heparin sulfate, the COVID is quite uncommon for SARS. SARS, the receptor binding protein is open, but for the COVID is an enclosed form. So that only in the open form it can only interact with ACE2. And the role of the heparin sulfate is twofold. First, it concentrates the COVID or the spike protein. Secondly, it turns it into an open form. And once it can, in an open form, in close proximity with the ACE2, then it leads to the thromboinflammation of the endothelium and initiate thrombosis and inflammations. And actually, this open form, actually, for example, Omicron, for the previous strain, D614G mutation, actually it will increase the open form. And secondly, it's also the hyperinfectivity is also by the upgrade of the heparin sulfate, because this heparin sulfate and this upgrade of this heparin in the endothelium will lead to the vulnerability of cancer patients with COVID infections. And this interaction can be blocked by heparinase or by heparin. So that actually heparin has a function not only to prevent thrombosis, it has another function that it can be an antiviral agent. But not all heparin sulfate, heparin can be used as an antiviral agent. The inhibiting effect is not good for the most commonly used heparin we are using in our hospital, for example, enoxaparin. Unfortunately, heparin is the most useful if you compare with you compare that with enoxaparin. Also, research are going into testing drugs, they do not have the coagulation effect or by use as an inhalation form. Even for that, anticoagulant with low molecular activation has also can improve decrease mortality and also decrease the duration of infections. So that we go to the whether messenger RNA can cause thrombosis. Although the incidence is low, is around 4 per million populations, but it's already tries that of Johnson & Johnson and similar to that of the AstraZeneca, although they are by different mechanisms. This is the blood of the patients with after vaccination with messenger RNA with Moderna. And from this, you know that the S1 antigen was detected as early as day 1 post-vaccinations. And they get a peak on average of 5 days after the first injections. And the mean S1 peak level was 6.68 picogram per ml. And also spike protein can be detected in 3 of the 13 patients, 15 days after the first injection. So that not only natural infections can lead to the production of free S1 protein in the body. Even messenger RNA vaccinations can lead to the production of free S1 protein inside the body. And in natural infections, for example, in natural infection, one of the common phenomenon is that they have a megakaryocyte inside the venous system of the brain. One of the features of pulmonary embolism, pulmonary hypertension, and pulmonary complications of COVID is that in postmortem, you notice a lot of macrophage inside the pulmonary circulations. And this megakaryocytes can produce a lot of platelets locally. And this can initiate thrombotic tendency. And in postmortem of the brain in severe COVID, 1/3 of them you can find this megakaryocyte. So that this hyperactivation, this megakaryocyte lined epithelium prone to thrombosis. And also, just the presence of S1 protein can lead to platelet hyperactivation, and the production of amyloid clots, which are resistant to fibrinolysis. And they can lead to fibrin formation in the absence of thrombin. Just add the spike protein, and then you to this fibrinogen, then you can produce clot in the absence of thrombin. So that this spike protein actually can induce hypercoagulation and endothelial damage directly without being taken up by the cells. So that the presence of free S1 proteins in the serum after Moderna immunizations may be a risk for the thrombosis. And because for the heparin, the heparin sulfate is concentrated on the endothelial lining in the cerebral venous system, and also in the presence of ACE2, there is a high. This may explain why after messenger RNA vaccination, you seem to have an increased incidence of cerebral venous sinus thrombosis compared with the ordinary general populations. And this is another study so that the spike protein can produce thromboinflammations. That is not only thrombosis, but they can also induce cytokine productions. So that thrombo inflammation can be induced by this spike protein. And also this spike protein can cause a blood-brain barrier in animal studies and by transcytosis. So that whether some of the CNS complications of natural COVID infections is due to the release of this spike proteins from the body, from a distal site, and then transfers to the blood-brain barrier to enter the brain to produce thromboinflammations and some of the complications of brain fog. Another topic I would like to comment is on the temperature regulations. Actually, for the most of the coronavirus in the past, they only survive at 33 degrees Celsius in the upper respiratory tract, and they seldom go into our lung. Only with the emergence of SARS, MERS, and COVID, they have traveled to our lower respiratory tract. So that the study on the temperature regulations for the survival of these viruses are important, because we'll have to know, because we have mentioned that is the virus are parasites. They have to use our body mechanism for survival. And also the enzymes they produce actually have to work on the optimum temperature, so that the genes that determine the optimum temperature for these viruses are important. And we have models for the of coronaviruses in rats, which is called the mouse hepatitis viruses. And mouse hepatitis virus, they have some called temperature sensitive mutants. So that whereas a dose of 100 parts per for these temperature mutants, even if the viral load is 1,000-fold, they do not kill the host. And this is due to the temperature controlling this temperature sensitive mutants are present in two genes. One and actually it's an interplay of these two genes. They are important for the viruses. As for the COVID, we find that actually they are also temperature sensitive. And COVID compared with SARS, actually they have survived better in cold temperature. And this seems to the temperature controlling this type of genes is on the non-structural gene 5. And we can manipulate it like non-structural gene 5 to turn it into a temperature sensitive strain. And this is and also you can use the co-adapted live attenuated virus, but they are only in the phase of development. But however, we know much more for the temperature regulations in influenza viruses. And we can make use of the influenza virus model to use vaccines. For example, the temperature regulation genes in influenza virus is the PP2 genes. And you know that most of the human influenza viruses, they have this type of mutations. And in the H7N9 outbreak, you found that all the patients, the 3 patients from Shanghai, have these mutations. But this mutation is absent in the poultry, in the live market in Shanghai. So that at that time, I emailed Wen Yang, saying that I know which birds they have missed, but to my disappointment, all the poultry have been slaughtered, so that we cannot confirm the diagnosis. And what is the importance of this PP2 gene mutations? This PP2 gene mutation is that in birds, they survive at 32 degrees Celsius, but if this PP2 mutation, they can survive at 33 degrees Celsius and 37 degrees Celsius. 33 degrees Celsius is the upper respiratory tract, so that it can spread through the droplets. And 37 degrees Celsius is our lower respiratory tract. They can lead to severe viral infections, hormone infections. And the mutations is only in, for example, in H5N1 avian virus, it's only 23.1%. For the human with 10 years outbreak, only increased the incidence of 24.65. But this cannot be explained in the Shanghai case. We have a 100% these mutants. So that I think that the most likely birds that is responsible is polio and emu. And why I think that and this is I can speculate this because actually that in 2005 there's an outbreak in Qinghai Wu, and 20% of these H5N1 have turned into these mutants. So that the biologists collect all the mutants of the PP2 genes and found that for duck and chicken, only very few of them will mutate into PP2 627. And only in some of special birds, ostrich, emu, rhea, this type of birds can lead to a high rate of mutations. And they can, if they grow in the eggs or they grow in the birds, very often they can rapidly select out these mutants. So that most likely is that because after 1992, the Mingling have tried to have this farm for this ostrich. And by 2004 is the highest production farm in the Southeast Asia for ostrich. And secondly, we look at the influenza viruses. For the influenza viruses, we have mentioned that they use nuclear kappa B for this replication and propagations. But once nuclear kappa B is activated, it will induce interferons. So that for the virus to survive, you have to have mechanism to suppress the interferon effect. And there are two types of interferons. One is a constitutive interferon, which are constantly produced. And second is the inducible interferon, which is produced only when you have infections. The most important is the constitutive interferon. If it's suppressed, then it will lead to severe illnesses. And for the constitutive interferon, you can block by the pre-transcriptional level and the post-transcriptional level. So that from the influenza viruses, we found that why is the pandemic Spanish flu so lethal? Because it can stop the interferon at both the pre-transcriptional level and post-transcriptional level. And for the ordinary influenza viruses, it can stop the production at the post-transcriptional level. And for the pandemic virus, it retains the double-shaped mortality. and only can can inhibit the interferon and the P-transcription level. But for 1997, the high pathogenic influenza virus can suppress the influenza B production at the constitutional level, and they have a 33% mortality. And 5 years later, after can adapt to human cells, they have 60% mortality. And in 2013, the outbreak of H7N9 is similar to 1997. They have 33% mortality. So that what is the bearing, knowing this influenza virus to the production of vaccine for COVID? One of the problems with the adenovirus type of vaccine is that we know that now they have a complication of PITT. And secondly, they cannot be used repeatedly, because once they are used, they can produce antibodies. And this type of adenovirus vector specific type of adenovirus cannot be used the second time, because you already have antibody. But for influenza, and it's very difficult to find the suitable adenovirus vector. We have only a few at hand, which have already been used in our vaccine productions. And we cannot use as a yearly vaccine. But for the influenza viruses, it's different, because we have a lot of influenza viruses. And so that you can use produce a lot of different types of COVID vaccine with this platform. And this is what Professor Yun have tried to do with this live attenuated vaccine. And they are using as an influenza-based vaccine to produce the SARS COVID vaccine. And they delete the non-structural genes, because so that without the non-structural genes, this live attenuated virus is not pathogenic. So that this is very genius, because we can produce different types of vaccine, and they can also produce influenza vaccine and COVID vaccine at the same time. Another platform, I think, will be the future is the virus-like particles. And they can use the influenza-like virus-like particles. We can be used for influenza vaccination, and also it can also be used for this platform for the use of a COVID vaccine COVID vaccine. And this is the viruses, the virus-like particles that are produced. They are very similar to the ordinary virus, although they do not have the genetic part. So that they are non-infectious, and they are safe for immune-compromised individuals. They can be produced in bulk and with a very high yield, and they have no risk of mutation due to a lack of genetic materials. And there are various platforms that can produce, because for influenza viruses and the problem if you use eggs, they maybe have a shortage of eggs. But if you use this type of other types of platforms, you can produce a lot of the vaccine within a short time for a pandemic purpose. And finally, I think the isolation and quarantine policy are very important. And if you look at the various outbreaks, for example, in the local H1N1, mass gathering is a cause of the outbreak. Another we have to look into details is that we may have a new H1N1 pandemic, because some of they have an antigenic shift in H1N1. And if this strain have come out we may have a new pandemic of H1N1. And if yes, and we have to look for the watch out for this pandemic, and not only only for COVID. And finally, I have a very short summary of the cytokine dysregulations of COVID. And you know that there are two ROS-induced cytokine dysregulation. One is for the mitochondria, and one is for the endoplasmic reticulum, which I previously mentioned. The endoplasmic reticulum one is the nuclear factor kappa B activations. The for the mitochondrial is the ferritin pathway. So that is very the influenza cytokine dysregulation is very similar to that of the COVID. We have one is concentrate on the nuclear kappa B activation. This is reflected by increase in interleukin 6 and C-reactive protein. And secondly is due to the mitochondrial dysfunction, which is characterized by ferritin, hyperferritinemia, similar to macrophagocytic syndrome. And what I like to mention is so that we have three types of cytokine dysregulations. One is the nuclear factor property related. One is the interleukin 1, interleukin 18, which is characterized hyperferritinemia. And the final, what I interest is the transforming growth factor beta 1, interleukin 4 type, which is for the fibrosis and long COVID. And I have only briefly mentioned for the mitochondrial one, which can be treated with, for example, by hydrogenase and IVIG, and also perhaps by cyclosporin A. What I would like to point out, one of the major difference between influenza and SARS is the fibrotic process. In the COVID and the SARS, we know that a lot of them have go into early fibrosis. And also in MERS coronaviruses, they are going into early pulmonary fibrosis. And this is due to the production of transforming growth factor. And why the SARS coronaviruses produce this transforming growth factor is try to inhibit the apoptosis in favor of the virus specking and replication in the early days of SARS development. So that in SARS and MERS coronaviruses, in early infections, we notice there's a rapid induction in the transforming factor beta. And steroid is ineffective in suppressing transforming growth factor beta. So that in SARS, we need to use pulse steroid in order to achieve, to suppress the transforming growth factor, but the effect is suboptimal, and we have a lot of side effects. And also for the MERS coronaviruses, the fibrosis, actually, they do not have a method for the treatment of the fibrosis. How about COVID? Unlike SARS coronaviruses, the pulmonary fibrosis always delayed, and usually the transforming growth factor is induced usually after the development of antibodies. And the problem is this may be one of the factors leading to long COVID. For example, in the renal cells, they found that after COVID, the cells that are affected will switch to a fibrotic process, fibrotic genes, and we induce a transforming growth factor, so that they will have renal deteriorations even after transient recovery. They will lead to long-term complications. So that the transforming growth factor beta that is produced by the immune cells, which is will be one of the contributor of the long COVID problem. And transforming growth factor beta is also induced during mechanical ventilations. So I think that this is some of the patients that we may encounter in our intensive care unit. In SARS, what is the treatment that we give to our patients trying to suppress their transforming growth factor? Is we give pentoxifylline together with vitamin E. Why we are giving pentoxifylline with vitamin E is that in the past, there is the most resistant fibrosis is irradiation-induced fibrosis. In the past, irradiation-induced fibrosis is irreversible. But later they found that if you give pentoxifylline together with vitamin E, actually many of them can be reversible. And one of the reasons for pentoxifylline is that they are a suppressor of transforming growth factor beta. And also the vitamin E, they can reduce the peroxidation defect. And in our treatment protocol, we want to complete the vitamin E cycle so that we also give zinc to the patient, we also give NAC to the patients, we give the selenium to the patient and riboflavin to the patients. It seems that they work in SARS, but we do not have any study, formal study on that. And we have not done any study in COVID. But I think that it may be a worth considerations in doing study for patients who have been elevated transforming growth factor or chronic phase of the lung damage. Okay, I think this is the end of my sharing.
Maybe I'll start the ball rolling. Maybe how about the treatment response in patients received a high dose NAC?
I can give you the details because I'm not the one who managing these patients.
I see.
As far as those patients who are admitted in the past low H1N1 infections, we give NAC to most of all the severely infected patients. And some of these have ordinary coronaviruses, metamuroviruses, or RSV. And I find that actually the C-reactive protein drop very rapidly with the infusion of NAC. So that I think we will worth study on the treatment because our treatment at the present moment is downstream and they have a long-term effect and we have a secondary bacterial infections. But for NAC, you do not have, it's an upstream. And also it can do not have a lasting immunosuppressive effect. From the study in 1997 for the influenza viruses, they found that NAC can improve the T cell function for those elderly patients. So that it will not, it's not immunosuppressive. So that you can monitor the C-reactive protein and give NAC. We can see that whether they respond to treatment.
I see. Actually, we use a low dose NAC only, and seems that it's not working really well. So yes. High dose NAC is more used.
Yeah, because actually you have to go into the endoplasmic reticulum. So that from the animal study for influenza is 1 gram per kilogram. But because the oral dose is only IV dose, it's one. The IV dose is we have only 10% bioavailability. So that in our treatment of a patient low H1N1, we use IV form. It's 100 milligram per kilogram per day, which is around 1/3 of those we are giving for a patient with paracetamol overdose. so that this is a quite safe dose as far as is concerned. From the study from Spanish, they are giving only 600 milligram TDS, but they are already considered as a high dose. Although you have the same survival benefit of steroid and enoxaparin. And we have already mentioned enoxaparin is not only as an antifibrotic agent, it can use as an antiviral agent. And also it can improve survival and decrease the persistence of the virus infections. Even it's not optimal as an antiviral agent because ordinary unfractionated heparin is much better in stopping the interaction of the heparin sulfate with the ACE2.
One question from the chat box is, when would you expect to have a new and better vaccine?
I don't know. I think the vaccination is a very complicated problem. In the past, we developed a vaccine in times of 10 years. But this time we develop vaccine within 1 year. So that some of these vaccine side effects have not been tested. I would like to share one of my concern. One is that this is a Swedish studies. First, the Swedish study found that the messenger RNA can be transcribed into DNA in human liver tumor cells, and in as far as 6 hours upon BNT exposure. And also ordinary SARS infections, the SARS coronavirus can transcribe its RNA into DNA of the human cell during COVID infections. So that whether COVID, because you know that for the hepatitis virus, we have hepatocellular carcinoma because of the genome of the hepatitis that has gone into the genome of the human cells. And in ordinary COVID infections, the RNA of the COVID can incorporate into DNA of human cell during natural COVID infections. So that another study is on the messenger RNA can incorporate in the human liver tumor cells. And this is the reason Sweden has banished the messenger RNA vaccination in its children. So that the long-term effect of, I think the long-term effect of vaccination is still incomplete. And the safest thing I think is that for the inactivated vaccine, which is all this type of technology is already present in 1957 at the year when I was born. But for the new one, we do not know. We do not really know. For example, the adenovirus vector vaccine, we can only know when we have a massive vaccination program, because the incidence is very low. For example, Johnson & Johnson is 1.7 per million, and even for AstraZeneca, it's 4 to 40 per million populations. So that if you do not have a very large population, we cannot detect it. We cannot detect this type of side effect of these types of vaccinations. So that any new vaccination, I think that it need time for us to know the side effect or the benefits. I think it will leave to the virology and the expert to answer these questions.
Thank you, Dr. Light. And another question related to vaccination is, do you think it's desirable to have a compulsory vaccination from the medical point of view?
I think for for the protection of the population as a whole, I think is necessary. And I think in certain, especially in certain type of people, for example, if you heard about Obamacare, in the past, the vaccination rate among for the healthcare workers in the United States is very low. But however, after some of the compulsory program, the vaccination rate has improved. But for COVID, I think if you think that is for security for the whole population, I think some measures to push the vaccination rate is very important. But I think it's up to the society to choose which is the best for them. But personally, I think that some compulsory measures is necessary for the protection, especially for the elderly populations, to decrease their mortality.
Sure. And one question is about the treatment of the COVID. Okay, what is the best time in the course of COVID-19 to start the pentoxaferin and also vitamin D? Vitamin E.
And pentoxaferin, I think, is the fibrotic phase. It's the fibrotic phase. The fibrotic phase is usually when the end. Usually, SARS and COVID are quite different in the secretion of the transformed growth factor. SARS and the MERS coronaviruses have a secretion of the transformed growth factor beta very early on, so that they lead to severe pulmonary fibrosis very early on. So that if I'm going to conduct a trial, I would start the trial very early from the onset. But for COVID, the increase in transformed growth factor is usually after they have antibody development, and this is the induction. So that I think this may be useful in the management of long COVID in study, so that whether they would improve the function of the patient who is on long COVID. So that I think the timing is quite different for these two diseases. But I'm not a researcher, so that I cannot answer your question fully. But for SARS and MERS, I would start it as early as possible. And for COVID, I only start it for the management of long COVID or pulmonary fibrosis. They have difficulties in meeting the ventilator, and we have an infection that we ruled out.
Thank you. And one question is from Dr. Yan.
Is there any role of the H2 antagonist, the famotidine, in the treatment of COVID?
And so from famotidine, actually, they have M protease inhibitor. They have two roles. Actually, the famotidine history comes from China. They find that for certain type of patients, even elderly patients, they have quite good prognosis, and they found that they have taken famotidine instead of omeprazole, because when they have a retrosterol pain, the rich one will take omeprazole, Nosac, and Pentalog, but for the poor one, will take famotidine. And they found that actually for those poor people, they have a better survival. And from docking study, they found that the famotidine is M protease inhibitors. And secondly is on the sinusitis regulations. And COVID is an allergic disease. And some of these actions can be prevented by famotidine. So that some of the study have shown that the famotidine have decreased survival, improved survival. But the study from Hong Kong have not found that famotidine is useful. But the Hong Kong study is that we have too little number of patients, and they want to taken care of all the comorbidities. So that I think it's very difficult for a small number of patients at that time to adjust for all the comorbidities. So that I think it's reasonable that it will be a negative study. But I think we already have a good drug, M protease that can decrease mortality, so that we do not need to take famotidine anymore. But having said that, I think that for patients admitted to ICU, for the patient on COVID, I think using famotidine as a prophylaxis may be a better choice than Panadol or Nexium.
And in case you have any questions, and just forward to me, and I may be able to send to 啦。And 唔該晒禮爺。